Good morning, good afternoon, and good evening from wherever you're joining us from. My name is Dr. Jemimah. I'm the founder of Wills for Life and Wills for Life Healthcare, and I'm really grateful to be here today. This is Wills for Life by Dr. Jemimah. Today we're going to be discussing about something that has bugged many of my patients, something that has brought a lot of psychological issues and infertility issues, and I'm talking about polycystic ovarian syndrome, commonly called PCOS. Thank you. Walk along with me as I explain what it is, how you can know if you have it, and how to live with it in life. Karibu. Polycystic ovarian syndrome is a very common disorder. It affects only women, and that's because it has hormonal patterns that are only known in women. It has many, it's a polyfactorial or multifactorial disorder. One, because it encompasses genetic issues, which means that women predisposed genetically to find this thing because of to have this condition because of a mutation in CYP1 gene. And then it has environmental factors. It has hormonal factors, which is a mainstay of the disorder. And then it has also syndromic factors. So we're going to be looking at each and every component with you. And I hope that by the time we're done, you'll understand to an effect what is polycystic ovarian syndrome. So polycystic ovarian syndrome is a condition that is brought about by very many issues, but the most common is genetics. There are women who, because of their genes, they are predisposed to getting polycystic ovarian syndrome. There's a mutation at a point of a gene, CYP1 gene, that can cause it. There are environmental factors like what you eat and how you exercise and whatnot, and that's actually one of the mainstays of treatment. And then the main issue is the hormones. So to simplify it for you, you think about the ovary as a factory. So when you look at the ovary as a factory, it produces two things. It produces eggs, and then it stores those eggs. And then the second thing it does is that it produces hormones. The main hormone produced by the ovary is the estrogen. And what makes a woman and a man different is estrogen and testosterone. And then the other thing that it produces is progesterone. So for this factory to work, it has to be told that there is a need by the body. So what tells the body that there is a need is another factory in the brain called the pituitary. And that pituitary has its own distributor, which is called the hypothalamus. So the hypothalamus tells the pituitary, we need estrogen. So it releases a hormone, which is called gonadotropin releasing hormone. So this hormone goes to the pituitary level and it releases two hormones, follicular stimulating hormones, which is the line that gives you eggs, and then it gives you luteinizing hormone, which is the line that produces the estrogen. And then these two go to the factory, the main factory in the ovary, and then because of follicular stimulating hormones, it produces eggs. And because of luteinizing hormone, it produces estrogens. So that's how to generally think about it. And if there's an imbalance in these three lines, three production lines, then you will have a hormonal imbalance. So when you think about polycystic ovarian syndrome, you need to think that the follicular stimulating hormone, or FSH, is less than the LH. So what does that mean? That you have eggs that are being produced, but they're not becoming big eggs. Therefore, ovulation is a problem. And then there's too much estrogen being produced, and because it's too much, it then does two things. It converts that estrogen to testosterone, and then it goes to the body and it makes insulin not respond well. So when insulin does not respond well, you have more fat deposition. Okay, so that fat deposition is what we call central obesity. You end up with a bit more fat around, especially your abdomen. So when that fat keeps on being deposited, it again responds by making insulin not work. And then the second thing is that it converts that fat to more estrogen, which are then converted to more testosterone. So why have I taken you through that? It's show you there's a conveyor belt. That PCOS is a conveyor belt of issues that have to do with hormones. There's insulin that has been made not to work well. And for those who don't know the work of insulin, when you eat any food, it is broken down to glucose. It is the work of insulin to make that glucose come down to normal levels and then to make it be converted to whatever should be. Either it will be converted to the liver, in the liver to glycogen and stored, or it will be excess, and if it's excess, it's converted to fat. So in the normal body system, when you have excess glucose, ideally it should be converted to glycogen, and then as you move, then that glycogen is converted back to glucose, and then you're able to use it to power your body. But if you have insulin resistance, it means glycogen will not be glucose will not be converted to glycogen, and because that pathway is lost or reduced, then you have more fat deposition through another pathway, and then you end up with diabetes mellitus and fat deposition. So how do you know that you have polycystic ovarian syndrome? You will have a big ovary. Why do you have a big ovary or a bigger ovary? It's because the eggs, or the smaller eggs that are being, those follicles that are being recruited. Remember, you're born with eggs. That's why I said it's a factory and a storage of eggs. You're born with eggs. These eggs are in small, minute things called follicles. These follicles every month are recruited by FSH so that you're able to get one dominant follicle or one big follicle that can then release an egg that will be fertilized. But in PCOS or polycystic ovarian syndrome, the follicles are recruited, but they don't grow big enough because the response to FSH reduces. Therefore, what happens? They're just pushed to the side. They keep being pushed to the side because none is growing big enough to ovulate. Okay, so you have a big a big ovary, which has small, many follicles, and those follicles on scans will look like cysts, which is why it's called polycystic syndrome, polycystic ovarian syndrome. So you have, when we look at your egg, it looks like many small ones. This is an image. This is a laparoscopic image. So if you look at the laparoscopic image, this is the ovary. The ovary, you can see it has these tiny things. Those are the follicles that I'm talking about. And then these follicles now start doing the second work of the ovary, which is to release hormones. So they'll release estrogen, the bad kind of estrogen, and those estrogens will be converted to androgen. So you can see it's rather big. It's almost 20 cc. It's really big. Okay, a normal ovary does not look like this. Okay. Oh, and this book is called Juta's Gynecology. Okay, so when I look at the scan image, and have a scan image here. When you look at the scan, you can see the big ovary, and then you can see the small follicles. So they're very tiny. They started growing, but they didn't exactly finish. And you can see because they are many, they're pushed to the side. So this ring is what, when we see, we know that's a polycystic ovary. But for you to qualify to be polycystic ovarian syndrome, it means you also have to have the symptoms. And what are the symptoms? One of the symptoms is weight gain. And why will you have weight gain? Insulin is not responding, you have central fat deposition, and therefore you have weight gain. The other thing is as a response to the high androgens, the testosterone that are being formed. So it will give you something we call acanthasis nigricans, which is a black line. See this lady? Are you seeing behind the neck? She's white, so if you're black, you may not have this same picture. But she has this black line. So that's called acanthasis nigricans. And you can see the acne here. Okay, so those two are as a result of having high testosterone levels. The other thing you can notice is hirsutism. Hirsutism means that you have male type distribution of hair. So you may have a beard from here, you may have a mustache, you may have chest hair, you may have back hair. All that is as a result of the higher androgens on your body, and we call it hirsutism. Okay, so the other thing that you may notice is that your periods are not coming. And why are they not coming? As I started, I said that there are many follicles being recruited, but none of them is growing big enough for you to ovulate. So it means that you will not have regular menses, and the menses that come, they can delay for 45 days and 90 days, some even as much as 6 months. So all those delays tell you that you have a period abnormality. And that period abnormality is because there's no proper balance between estrogen and progesterone, because the body is not producing well enough, because, as we said, the hormones are not, the LH, FSH are not well balanced. Okay? So in order for you to ovulate, you need a surge of LH, but beyond that, you need a surge of estrogen. Okay? So you're not ovulating, you're having delayed menses, and then because of that, you're going to have struggles with infertility or conceiving. Does that mean that everyone who has PCOS is going to struggle with fertility? No. Does that mean that everyone with PCOS has weight gain? No. But these are symptoms that we keep seeing from one person to another. There's something called thin, lean PCOS, that they're small in body, but when you check, they have all other factors. They have the acne, they have the increased hair distribution or hirsutism, and most of all, they'll struggle with infertility. So that's just to warn you not to tag someone just because you've seen them on the road. So the third thing that we check, or how we diagnose PCOS, is using something we call the Rotterdam criteria. So people sat down in a conference in Rotterdam, gynecologists, and then they looked at patients with this particular syndrome. And they found that you can either diagnose them clinically via their symptoms, sonographically with that image that I showed you or something similar, and then third, they check with biochemically. Biochemically, what do I expect to see? I'll see a level of insulin resistance. I will see higher testosterone level or androgen levels. I will see a mismatch in your LH, FSH. What does that mean? Your FSH will be lower than your LH by 2:1. Okay, and then your progesterone may also be affected. So these are the things that we check. Right now, we say if you have higher androgen levels and you have sonographic or clinical features, we can comfortably say that you have polycystic ovarian syndrome. So how do we manage polycystic ovarian syndrome? Management of polycystic ovarian syndrome is dependent on you. Really depends on what are your goals at this time. So for example, if your goal is to regularize your periods and not exactly to conceive at this time, then we know we want to balance your hormones. There are many medications that have come to try and balance hormones using multivitamins. We have the likes of Hyponid, We have the likes of ionositol or myonositol, dechiron, all this. All of them try to balance out, they have enzymes that try to balance out the natural hormones. But we don't want you going beyond 3 months without your periods. So we may put you to begin with on combined estrogen contraceptive pill, progesterone contraceptive pill. So why do we give you combined estrogen and progesterone? Because there's a deficit in your body of both estrogen and progesterone. So we don't want unopposed estrogen. So we want to give you estrogen plus progesterone at a particular rhythm, so that one, we teach your body the rhythm, but then two, it allows you to have your normal 21-day gap and then a bleed in between. Okay, so we take pills for 21 days, and then on the 7-day gap, we know that you're going to bleed, and then you continue. So that is, especially if you don't have any other adverse, anything that will prevent you from using the pill, for example, hypertension or diabetes, then we're able to use that effectively to control your hormones. Okay, if your issue is hair, or if you notice that you have excessive hair, we can give you anti-androgens to help you with reduction of excessive hair production. It may not remove what's already there, but it will prevent further hairs from coming, and then it will also soften the ones that are already there. For hirsutism, you may need to do things like laser or waxing to help you with reducing, but I would really advocate to avoid shaving, because when you shave, you grow longer, more coarse hair. So maybe waxing or laser can be options for you, but we do have anti-androgens, for example, spironolactone or aldactone, that can be used to reduce that, but with caution and with the advice of your doctor, because it can also lower your blood pressure. Okay, so that is on hirsutism. If the concern is weight gain or insulin resistance, we do your HbA1c levels and find your sugar levels are a bit high, or we can tell that you have increased insulin resistance, then we may give you an insulin sensitizer such as metformin that can help you balance out your can help your body respond better to insulin. So it's an insulin sensitizer. Okay, if your issue at the moment is fertility, then now we go into ovulation induction using the medications that are available to us. And we would advise, before you try and do ovulation induction by yourself at home with the known medications, please be seen prior, so that you don't, for example, have a cyst and you try and use the types of clomiphene, because they can affect you. Okay, also for most places it's a prescription medicine, so you made it a prescription before you actually buy or purchase the drug. Okay, so I think that's the most common medically that we use, but there are other things, especially if you're not responding fertility wise, that we can go to. For example, surgery. We have what we call ovarian drilling. If the ovary is too large and there's a reduced response because of the thickening of the serosa or the covering of the ovary. So that's something else that we do. Not very often. Your doctor would really have been pushed to the wall to take you for ovarian drilling. We also have very good responses with treatments such as IVF or intrauterine insemination, depending on really your spectrum. So as I've said, management is really based on you, and it's patient-centered. Every patient will have a different management for their PCOS symptoms. Is it something that can be cured? Not really. It's something that we manage, but there's always a space for, you don't know, science surprises us daily. But one thing that you can do at home is, if you reduce weight by even just 10%, then most of these things resolve by themselves. Your body is able to auto-regulate its own hormones, because the insulin resistance goes down. So exercise, diet is very important. Multivitamins are also very key to help your body in terms of regulating and balance itself, especially with zinc, magnesium, very important for you. So I hope that helps someone. And the last thing I'm going to mention today is the long-term effect of polycystic ovarian syndrome. So, for example, if you've stayed 6 months without period, then that means you have 6 months of unopposed estrogen in your body. What does that do? It will cause continuous proliferation of your uterus as it's trying to prepare for this baby that's not coming. So that unopposed estrogen exposure can lead you to getting endometrial hyperplasia, and if left for too long, it can bring endometrial cancer. So that's why we're very keen to make sure at least bare minimum, after every 3 months, you have gotten your periods. If it can be monthly, the better. And that's something that we've noted with reduced weight and exercise. It can actually come to having regular menses without the help of pills. The other thing that we notice is if you have increased insulin resistance, in future, you're likely to have diabetes mellitus. You're likely to have obesity. You're likely to have metabolic syndrome, which combines high cholesterol, hypertension, and diabetes type 2. And these are things that if you know you have polycystic ovarian or the genetics that carry it, kindly work on it mapema or work on it earlier so that you don't go into that metabolic syndrome spectrum. And of course, with infertility, there's a lot of stigma from the population or from the community. And it's important that you don't allow it to go into now anxiety, especially if you're doing fertility treatments, or depression, or other psychosomatic disorders. So I hope that someone has been helped today. There's something you can do about it. If you've seen some of these symptoms, please talk to your doctor. Start exercising. Eat the right kind of food. Reduced carbs, more protein, more vegetables. It's your regular diabetes type of diet actually, and that will actually improve you. If you don't have a gynecologist, if you'd like to come to us, we are located at CK Patel, 9th floor on Kenyatta Avenue in Nakuru. And if you're not in Nakuru, you're able to find us online. We have a virtual app. It's called Wheels for Life. You can look at it from Google Play. You can find it on App Store. Please book your consultation. We can work with you. And if at all you'd like to reach us on call, number is 0719 116611. Thank you for joining us for this episode. I hope to find you in the next one. Subscribe, like, share, and God bless you.
Life is busy and sometimes health concerns can't wait. With Wheels for Life, healthcare is just a tap away, anytime, anywhere. Whether it's a fever, a routine checkup, or something urgent, Wheels for Life connects you with licensed doctors in minutes. Get expert care from trusted doctors, specialists, and counselors without leaving your home. From prescriptions to follow-ups, Wheels for Life helps you manage your health on your schedule. With Wheels for Life, healthcare is no longer a hassle. It's fast, secure, and always within reach. Download Wheels for Life app from Apple Store or Google Play Store today. Wheels for Life, fast, convenient, and secure healthcare in the palm of your hand.